So we will give everyone a minute or so to log in. We saw the people were already logging in, so excited to see you all here this evening with us. And I am extremely excited and honored to have Dr. Kelly Salmon with us this evening. She's been a really good friend and mentor of mine for a long time, so excited to have her here with us this evening to talk about total laryngectomy. A couple of just housekeeping items before we get started. This webinar is eligible for 0.1 ASHA CEUs or 1 PDH. To get ASHA CEUs, we do ask that you stay for the entire 60-minute duration of the webinar and that you complete a brief survey. Today is Thursday, so we ask that you complete by next Thursday because we want to just submit that to ASHA and get you your ASHA CEUs quickly. And then if you'd like a certificate of completion, we just ask that you email us at tims-univ@tims.com. Typically, we get back to those requests within 7 days or so. And then this webinar is being recorded and it will be on the TIMS website within 24 to 48 hours. And Kelly has been super gracious and has given us resources to provide for you all, references and slides and whatnot. So super grateful for that. And those will also be on the TIMS website. And if you didn't catch all this, it'll be in the chat as well and sent out via Zoom emails. So with that, I'm going to hand over the floor to Kelly.
Great, thank you, Brooke. I am going to go ahead and share my screen and then we'll get into it here. All right, allow. Great, all right. Welcome, everyone. I am honored to have the opportunity to present to you all this evening on a unique topic, which is talking about the swallowing system and how it functions differently after total laryngectomy, which is a patient population near and dear to my heart, one that I've really enjoyed having the opportunity to work with over the course of my career. So the presentation is titled From Airway Protection to Bolus Flow. So we're going to touch on how the swallowing system is a little bit different in total laryngectomy, and as such, how we might approach the assessment and treatment of swallowing in this patient population. All right, so let's move forward. So a little bit about me. I am a speech language pathologist that has specialized in working largely with the adult population over the course of my career. And I've had the opportunity to work across the continuum of care from acute care through the outpatient setting. So I've had the opportunity to kind of see how these different disorders of voice and speech and swallowing might progress through the different stages of acuity over the course of time. I am a board certified specialist in swallowing and swallowing disorders since 2011. I've been a board certified lymphedema therapist since 2014. And most recently, I completed my PhD studies in biomedicine, and my research focused on exercise-driven approaches to strengthening the perihyaloid musculature. So stay tuned for that to hopefully be published and available relatively soon. One of the topics and areas that I'm passionate about is device-facilitated and exercise-based therapies for medically complex patients, including those who have been treated for head and neck cancer. Disclosures are all listed here for your review and will be also available in the handouts. The learning objectives for this evening are to be able to describe the anatomic and physiologic changes to swallowing following total laryngectomy, to differentiate dysphagia mechanisms in laryngectomy versus non-laryngectomy patients, identify common swallowing impairments, physiologic deficits, and clinical presentations in individuals post-total laryngectomy, and apply evidence-informed strategies for the evaluation and management of dysphagia in this patient population. The agenda in terms of the topics and how I hope to cover them time-wise over the next hour is listed here for you. And then we'll get right into it. So what makes this patient population unique is that through the surgical procedure of removing the larynx and the other structures associated with the laryngeal framework, we are creating an entirely different system anatomically from what we would typically see in a healthy adult individual. So the myth in this patient population is that no aspiration means no dysphagia. But that fundamentally is incorrect. This assumption is one of the most common misconceptions in post-laryngectomy care. The absence of a traditional shared physiologic space, what we typically think of as our pharynx, sharing space between our airway and our esophagus, the fact that those two pathways are now surgically separated, it does not eliminate swallowing dysfunction, but again, it fundamentally changes it. So dysphagia after total laryngectomy is generally driven by the altered anatomy and not as much on the focus of airway protection and aspiration risk. We will talk about some exceptions to that when aspiration may be a concern, or how aspiration can still happen in this patient population. But largely, we're going to focus on the dynamics of how bolus flow changes through the new system after a total laryngectomy surgical procedure. So the reality after total laryngectomy is that up to 87% of patients report significant swallowing difficulties following a total laryngectomy. Again, despite in most cases the elimination of aspiration risk, dysphagia remains a major post-surgical complication, again affecting bolus flow, swallowing efficiency, and overall quality of life. So some of the burdens on the patient are that they will report food sticking and prolonged meal times as a result, dependence on compensation, in particular liquid washing techniques. So they're going to tell you that they have to use a lot of water or a lot of liquid during meal times to keep things moving through this new system. As a result of the challenges that they may experience during meal times, they may become more isolated socially and avoid meals in public or avoid meals sitting down with other people. As a result, there can be that significant impact on quality of life and resulting psychological distress. So again, swallowing impairments after laryngectomy is not rare, and recognition of these symptoms and having the ability to target those issues through management are essential. Okay, so this presentation assumes some baseline or basic knowledge of the differences in anatomy pre and post total laryngectomy, but we'll review some of the key components in terms of structures that are impacted as a result of this surgical procedure. So total laryngectomy results in the removal of critical anatomic structures that alter swallow physiology. Being able to understand these losses or changes is essential for accurate clinical assessment and targeted intervention. Number one, the larynx is removed as part of this procedure. So complete removal of the thyroid cartilage, all of the intrinsic laryngeal musculature, including the vocal folds, the false vocal folds, the arytenoid cartilages, and the musculature that attaches the thyroid cartilage to the other structures within the laryngeal framework, attaching the thyroid cartilage to the hyoid bone, thyroid cartilage to the cricoid cartilage. As a result, we are now going to be surgically separating the airway from the pathway for food to flow into the esophagus. So when we remove the larynx, we're also removing other parts of the laryngeal framework, including the hyoid bone. And when we resect that hyoid bone or remove that hyoid bone, it will disrupt the laryngeal extrinsic muscles that are normally attached to it. So that includes our suprahyoid musculature, like the digastrics, the mylohyoid, the geniohyoid, the stylohyoid muscles. It will disrupt those muscles and their function because they no longer have their point of attachment. From an infrahyoid perspective, here's where we're losing attachments for musculature like the thyrohyoid muscle, sternohyoid, and the omohyoid muscles. And again, those muscles previously, their job was to play a role in hyolaryngeal excursion, which we again focus on as part of our swallowing assessment in an intact individual. So with removal of the laryngeal structures and the hyoid bone, so we're again talking hyoid bone, thyroid cartilage, and cricoid cartilage, we're now losing that whole process of laryngeal elevation and hyolaryngeal excursion. So we're no longer generating that movement pattern that would typically impact airway protection and also play a role in the mechanical traction force that is responsible for pulling open the pharyngoesophageal segment during swallowing. Lastly, our swallow system is a pressure-based system as the bolus moves from the oral cavity through the pharyngeal cavity and into the esophagus. So the dynamics of how pressure changes is going to be impacted by this surgical procedure as well. One pressure factor that is impacted is subglottic pressure. When we have glottic closure, where the vocal folds adduct and we build pressure below, that is creating an area of high pressure in order to protect the airway and to drive the bolus towards an area of lower pressure. And in an intact system, that means driving the bolus towards the esophagus with an open pharyngoesophageal segment. So with all of those structures that are impacted or sacrificed or lost as part of this procedure, now we have to think about what is created in terms of this new swallow system. So this total laryngectomy procedure will restructure the upper aerodigestive tract, again, surgically separating the airway from the pathway for food to travel. So understanding that newly formed anatomy is essential to be able to accurately evaluate and manage post-laryngectomy dysphagia. So some of the new structures or new components include the neopharynx. So that is what it sounds like, the new pharynx. This is the surgically reconstructed pharyngeal cavity that is formed after removal of the larynx. It is going to serve as the primary bolus transit channel from the oral cavity to the esophagus. As such, the neopharynx is a reconstructed conduit. This altered tissue configuration after laryngeal removal is our pathway for food and liquid to travel. Now, the type of reconstruction that is performed as part of the total laryngectomy surgery, again, when you remove all of those important structures anteriorly, like the hyoid bone, thyroid cartilage, cricoid cartilage, and a few rings of the trachea, you're creating a huge physiologic defect. There's a bunch of space that needs to be filled. And so there are different techniques, which we'll cover in one of the following slides. There are different techniques for how we close that area to create this new pharyngeal space. And the type of reconstruction will significantly impact the geometry of the pharynx, compliance, and how well the bolus is able to clear through that space. Another change is within the pharyngoesophageal segment. This segment is the primary gatekeeper for bolus flow. So this is what needs to valve. It needs to be open to allow the bolus to pass into the esophagus and ideally close when it needs to be closed to prevent material from returning from the esophagus back into the new pharynx. Dysfunction at this level of the pharyngoesophageal segment is one of the leading sources of what we'll call outflow resistance. So if we're trying to move the bolus out of the pharynx or the neopharynx into the esophagus, outflow resistance is resistance to the flow of that bolus in the direction that we're intending it to go. And then another consideration in this population is tracheoesophageal puncture. Now, not every individual post-total laryngectomy is going to have a tracheoesophageal puncture procedure performed. This is the puncture that is created for insertion of a voice prosthesis in order to restore communication post-operatively. Typically, when it comes to tracheoesophageal puncture, there is a set of criteria for candidacy that is evaluated pre-operatively. In some cases, if individuals are deemed a good candidate for a tracheoesophageal puncture, it can be performed at the same time as the total laryngectomy procedure, or it can be performed as a secondary procedure at some point in time after the total laryngectomy procedure has been performed and the tissues have healed. So, as I alluded to earlier, there are many different techniques for reconstruction of the defect that is created as a result of the removal of structures during a total laryngectomy procedure. So the reconstruction matters, or the type of reconstruction matters, because how it may impact bolus flow or swallow function can vary or can be different depending on the type of reconstruction that is performed. So I have 4 different types of reconstruction listed here. There can be other sites from which a flap of tissue is harvested to create the new pharynx. But these are some examples and some of the most common options or approaches for reconstruction. So the first is primary closure. So in some cases, there is enough remaining tissue after the resection to be able to pull the margins of that tissue together to create the neopharynx and to create closure. So some of the advantages with a primary closure would be there's more natural or native physiologic tissue present. There may be better sensation. And there often can be more efficient bolus transit, especially if we have some ability of the remaining pharyngeal constrictor musculature to squeeze and to contract. Challenges are that there is a high incidence of stricture with primary closure and often a good amount of pharyngoesophageal segment dysfunction. The second type of reconstruction option that I have listed here is a radial forearm free flap. So this is where tissue would be harvested from the surface of the inner surface of the anterior arm. And when we talk about this type of tissue, the advantages of this tissue are that it is generally thin and pliable or flexible tissue. It can create a nice diameter of the lumen of the new pharynx, and there are generally favorable swallowing outcomes. The challenges: reduced sensation and variable contractility. The next is an anterolateral thigh free flap. This is probably one of the most common sites for harvesting tissue for reconstruction of the new pharynx. It gives excellent tissue volume, so it's coming from the thigh or the leg, and you can harvest a little bit of a larger bit of tissue to perform the reconstruction. So there's a little bit more bulk to the tissue than you would have with a forearm flap. And it's a versatile reconstruction option. So they can often, they have a little more tissue, a little more bulk to work with, so they can reconstruct that pharynx, depending on different lengths or widths that they need to adjust for. The challenge is that the bulk of the tissue itself may increase resistance, and we'll talk about the impact of resistance in terms of bolus flow. And sometimes, because it is bulkier tissue, we may have redundant tissue that creates structural impedance to the bolus flow. And I'll give some examples. They would be things like a pseudoepiglottis, where there's a fold of this tissue that appears as if it looks like an epiglottis on imaging, which then can resist the flow of the bolus, or create a pseudo diverticulum or space or pouch within that reconstructed tissue that again creates resistance to that bolus moving through the pharynx. Finally, another reconstruction option is a jejunal free flap. So here we're harvesting a portion of the small intestine or the jejunum. And the advantage here is it's already in a tubular form, and it has a mucosal lining. The challenges are that in some cases, when you're harvesting a portion of the jejunum, it retains its kind of peristalsis or peristaltic wave, and that can create a mismatch in terms of timing it with the individual's swallowing. So it may result in dysmotility and a higher volume of complaints of food sticking within the neopharynx. So when it comes to talking about head and neck cancer, laryngeal cancer is no exception when it comes to the potential for radiation treatment being considered as part of the definitive course of treatment. So there are many cases where someone not only undergoes a total laryngectomy surgical procedure, but they also need to follow up with a course of radiation treatment with curative intent for their disease. So in cases where radiation is also a factor, we see similar results in total laryngectomy as we might see in other head neck populations where the radiation has an impact on the tissue and therefore has an impact on function. So in individuals that undergo radiation, what we see is that the compliance of the tissue is reduced, and the distensibility of that tissue or the ability of that tissue to stretch is also reduced. When we have decreased compliance and decreased stretchability or distensibility, that will lead to increased resistance to the flow of the bolus within that new pharynx. So we know that in general, radiation effects include fibrosis or stiffening of the tissues. It can result in stricture formation or narrowing of that space. And radiation can also result in internal and external lymphedema. I mentioned internal specifically here because we're focusing on the swallowing and the flow of the bolus. And if we have edema or swelling, that can certainly create resistance to the bolus flow. Radiation transforms a flow problem into a resistance problem. So the resistance that's being created is impacting the ability of the bolus to flow through the new pharynx. So the new swallowing system, after a total laryngectomy, the bolus pathway is significantly altered. It's, again, separated from the airway, but that doesn't mean that we're still not experiencing issues with the efficiency of the swallow. So the sequence that we're looking at here traces how a bolus travels through the reconstructed anatomy from oral preparation to esophageal entry through the PE segment. So we know in the oral cavity, this is where our entire swallowing process is starting. So it's an important component because we talked about the pressure-based system for swallowing, and it all starts with building pressure within the oral cavity through a seal of the lips and also the tongue up to the roof of the mouth, the cheeks increasing their tone to narrow the oral cavity, all in an effort to increase the intraoral pressure to help drive the bolus from the oral cavity into the pharynx. Then we have the tongue base, which needs to drive up the pressure behind the bolus in order to efficiently push it through the pharyngeal cavity towards the opening of the esophagus. Within the neopharynx, again, the reconstructed pharynx is going to channel the bolus from superior to inferior towards the esophagus. Now, in this text box here, I said that pharyngeal constriction provides propulsive pressure, So the asterisk there is that the pharyngeal constriction component will depend on the type of reconstruction that has been formed or used to create the neopharynx. So if it's a primary closure and we've retained some of those pharyngeal constrictor muscles, we may still be able to generate some pharyngeal constriction and some force to squeeze that bolus into the esophagus. However, if the neopharynx has been created through a harvesting of tissue from elsewhere, like the arm or the thigh, when we create that new pharynx, it's what we call adynamic. It's just a tube and it's a conduit for the bolus to move from the mouth to the esophagus, but it doesn't have the ability to squeeze or to contract like our pharynx would without or prior to the total laryngectomy. So pharyngeal constriction can help propel the bolus in some cases, depending on the type of reconstruction. Otherwise, the neopharynx is adynamic or not contracting or non-contractile. So it really, again, is more of a passive tube or a bit like a funnel where we're relying more on the gravitational pull and the propulsion from the tongue base to push that bolus through the new pharynx. And then, as I mentioned earlier, the pharyngoesophageal segment is that gatekeeper to bolus flow. It has to dilate, it has to open to allow the bolus to flow into the esophagus. If it doesn't open to its full aperture, or it doesn't stay open long enough in terms of duration, then that is going to create resistance to the bolus flowing into the esophagus. And as I alluded to earlier, dysfunction at this level is the most common source of dysphagia in this population. So our traditional dysphagia lens, when we're evaluating swallowing in an individual that has an intact larynx and an anatomically intact swallowing system, the conventional framework for dysphagia management often centers on airway protection and preventing aspiration. Yes, we do also look at swallowing efficiency in addition to swallowing safety. But when we're looking at the swallow safety component, these are the principles that typically guide our standard clinical assessment and our selection of intervention strategies. We often prioritize the airway protection over the swallowing efficiency. So when we're looking at the safety component, first and foremost, with aspiration, it's one of our primary concerns, detecting and preventing entry of the material into the airway. Now, we know that not all aspiration is created equal, and that aspiration does not equal aspiration pneumonia or result in negative outcomes in every patient, but it is certainly something that we pay attention to and we consider when it comes to making decisions about whether or not we are going to intervene from a management or rehabilitative perspective, and to make decisions regarding any potential dietary modifications. In that same vein, we're looking at airway protection and the layers of airway protection and how those are functioning. So we're looking at laryngeal valving, like vocal fold adduction. We're looking at hyolaryngeal excursion, that superior and anterior movement of that hyolaryngeal complex in an effort to move the airway out of the path of the bolus for airway protection. And we're looking at the third layer of movement patterns of the epiglottis to cover the airway in an effort to divert the bolus away from the laryngeal vestibule. So we're paying attention to all of these valving and closure mechanisms as kind of being the cornerstone of swallowing safety. And then when it comes to swallowing safety in general, we're ensuring that the bolus, to the best of our ability, does not penetrate or enter into the airway, and we look at those safety metrics based on findings from instrumental assessment and use that information again to prioritize treatment. So if we can identify what the dysfunctional components of the swallowing are that are leading to concerns about swallowing safety, we can then choose the best therapeutic approaches to address those dysfunctions. Now, when it comes to total laryngectomy, again, the focus shifts somewhat. After total laryngectomy, we don't have that same shared physiologic space where we're concerned about protecting the airway. And instead, we're pivoting our focus towards how the bolus is flowing or the mechanics of bolus flow, swallowing efficiency, and we're looking at that underlying issue, which is the resistance-based dysfunction. So again, we're moving a bit away from the swallowing safety component and looking more at swallowing efficiency. So we look at bolus flow. We assess the pathway from the oral cavity through the neopharynx and the PE segment. And our focus is now flow dynamics. So how is that bolus flowing through the new pharynx? And that becomes our primary clinical concern. So in terms of swallowing efficiency, we evaluate the ratio of propulsive force. So how well are we generating the push or the force behind the bolus? And we're comparing that to the relative amount of resistance to the flow of the bolus. A successful swallow in this system means that we're clearing the bolus completely with minimal effort and no compensatory strategies. Resistance and residue are other areas that we're paying attention to. We're looking for things that may create resistance to the bolus flow, like hypertonicity of that pharyngoesophageal segment, the role that fibrosis may be playing, stricture or narrowing, pseudoepiglottis, pseudodiverticula. We're looking for any or all of those things as potential sources of increased resistance that lead to residue and those patient reports of food sticking or needing to use a significant amount of liquid to help clear that bolus through the pharynx. Now, some of the core principles that we've talked about in terms of swallowing safety and swallowing efficiency, when we talk about swallowing safety, this is in the context of, in general, when it comes to the total laryngectomy population, aspiration is not a significant concern unless, number one, there's a concern for a fistula, which is a communicating tract between the new pharynx and the airway, or in some cases, depending on the reconstruction and neck dissections, there can be communicating fistulas between the new pharynx and the outer portion of the neck. But in this case, we're looking at fistula between the trachea and the neopharynx. So if that occurs, if there's wound dehiscence or there's breakdown in the areas where the neopharynx was sutured together, there can be an opening that leads to material passing between the neopharynx and the airway. And the other situation or case where aspiration may be occurring or may be a concern is in individuals who have had a tracheoesophageal puncture procedure and they have a voice prosthesis in place. There are protocols and troubleshooting protocols that exist to identify and address aspiration that is related to leakage through or around a voice prosthesis. And that can be a whole topic and a whole lecture in and of itself in terms of determining why we're getting material coming through the prosthesis versus around, and then various solutions to that particular issue. So again, swallowing safety, there can still be aspiration in individuals who have a total laryngectomy, but typically it's one of two scenarios that are causing the aspiration. Now, with swallowing efficiency, as I mentioned earlier, it's really kind of this balance between generating enough force to propel the bolus through the new pharynx compared to the amount of resistance that may be present that is impeding the flow of the bolus through the new pharynx. So efficient swallowing really depends on that balance between those two forces that drive the bolus forward. When resistance exceeds the amount of force that someone can generate, dysphagia results. So how do we generate force? Successful bolus transit after total laryngectomy depends on adequate force to overcome resistance that may be present at the level of the PE segment, or as we'll see in the following slides, there are other sources of resistance that could be present. So there's 4 key contributors that create the driving force to push that bolus through the neopharynx. Again, one is tongue base retraction. So posterior movement of the tongue base generates the primary driving pressure to push the bolus through the neopharynx. The second force is gravity. So having someone in an upright posture and having that kind of head neutral position are going to try to take advantage of gravitational forces to help with bolus being pulled down towards the esophagus. Pharyngeal constriction, again, the asterisk here is that whether or not we have any pharyngeal muscle contraction is going to depend on the type of reconstruction and whether or not we have any of that pharyngeal constrictor musculature maintained or present in order to create that driving force. And then there's characteristics of the bolus. So the volume of the bolus, the viscosity, and temperature may all influence the ease of transit and the degree of force that is required to achieve that efficient clearance. So generally, it's easier to clear a thin liquid bolus through the neopharynx than it is a pureed or a solid masticated bolus. Now, we talked about this outflow resistance, and the truth is that not all resistance is created equally, and not all resistance is the result of a narrowing or a stricture. While that may be one of the most common causes of resistance, there are different mechanisms that all create that same symptom that patients report. Food gets stuck. So some of the resistance generating mechanisms include hypertonicity, so too much tone or tension in that new pharynx, in that tissue, fibrosis or stiffness of that tissue, stricture, which again is the narrowing of that tissue. The reconstruction method can result in resistance, and internal lymphedema or swelling of those tissues can create resistance. So again, these are those sources of resistance, but with a little bit more detail. The PE segment and hypertonicity of that segment, elevated resting tone is going to create resistance to bolus flow. Stricture is going to mean that the lumen of the neopharynx is narrowed, so the aperture is smaller. And if you have a smaller space to try to drive the bolus through, it's going to create more resistance. Fibrosis or stiffening of that tissue is going to reduce the compliance or the elasticity of that tissue, and therefore reduce the ability of that tissue to stretch in response to trying to push that bolus through. And then we have those structural issues that can be created as a result of the reconstruction and the type of reconstruction that's been performed. So there can be redundant mucosal folds or tissue flaps that create a pseudoepiglottis or a pseudodiverticula or pouch that is going to get in the way of bolus flow and therefore create resistance. And then with internal lymphedema, we know that lymphatic fluid accumulation within the pharyngeal tissues can increase the bulk of those structures and also reduce the elasticity, pliability, and distensibility of that space. And the tissue resistance, again, will disrupt bolus flow as a result, could result in residue and also have an increase in the resistance to that bolus flow. So what do our patients typically report? Patients frequently report a distinct cluster of swallowing difficulties driven by the altered bolus flow. The complaints, they reflect underlying pressure flow dysfunction rather than an aspiration or safety related issue. So they typically, again, report food gets stuck. I need a lot of liquid to help push things down or rinse things through when I'm eating. It takes multiple swallows to try to get things to go down. And they may report regurgitation and that it takes them a really long time to get through a meal. As I mentioned earlier, not only is this a functional challenge for these individuals, but it can have a significant impact on quality of life. So it extends far beyond the process of swallowing to impact emotional and social well-being. So it may result in social isolation when eating becomes challenging. If eating in public is a source of embarrassment or anxiety, it can lead to withdrawal from those social-based situations. Psychological distress, anxiety, depression, reduced self-esteem are very common. Losing the ability to eat normally profoundly impacts many areas of psychological well-being, like identity, relationships, and emotional resilience. People may avoid meal times. They may have this fear of choking, even though those two structures are separate, that the feeling that they get in terms of the food sticking may give them that sensation of, choking, even though technically that's not what is happening. Prolonged meal times, discomfort, and therefore later on down the line, reduced oral intake, weight loss, declining physical health in the worst case scenario. Finally, dietary restrictions. People may self-restrict to only eat soft foods, soups, liquids, shakes, because of how difficult it may be to manage anything that is more viscous or that requires mastication. And then I just mentioned on this particular slide, there is a patient-rated outcome measure specific to swallowing in total laryngectomy, and that is the swallowing outcomes after laryngectomy tool. So that is a helpful tool to give the patients to get a sense of their self-rated impact on their quality of life in terms of swallowing after laryngectomy. All right, so in terms of assessment, in this population, we use a lot of the same tools that we would use in individuals with intact anatomy. We still use video fluoroscopy. We may use FEES, and then two other technologies that may not be used as frequently or as commonly in everyday clinical practice, but are still useful in this population are high resolution manometry and EndoFlip, which I'll talk about both of those here in the coming slides. So with video fluoroscopy, I would say that this is probably the most common post-laryngectomy swallowing assessment because it does give us the whole picture from the beginning of the oral phase through the esophageal phase of swallowing. And it is something that we can get kind of the big picture view of those pressure-based relationships and the propulsive force versus the resistance factor. So when we're looking at video fluoroscopy in this population, we are looking at bolus flow, tracking the transit of the bolus through the neopharynx and the pharyngoesophageal segment. We're looking at residue and where we see it. We're looking at structural abnormalities. Again, we could be looking for things like pseudoepiglottis, pseudodiverticulum, PE segment dysfunction. And we may be able to also perform quantitative analyses, measure timing, clearance, residue percentages, and flow dynamics. When it comes to fees, we may still use or have the option to use fees in this patient population. Some of the strengths of using fees in this population are the direct visualization of the pharyngeal residue and the bolus flow. In this particular image, we're looking at the esophageal flange of a tracheo-esophageal voice prosthesis. So it can be useful to look at the positioning of the voice prosthesis, see if that's creating resistance, make sure that it's well positioned. But we can also look at the effectiveness of strategies and maneuvers. With fees, it also gives us a more direct evaluation of the soft palate and velopharyngeal seal. So there's many different benefits to fees, but we know that some of the limitations are that we can't visualize the oral preparatory phase. It gives us limited pressure and resistance data points. The image quality is operator dependent, and it really doesn't give us a whole lot of information about what might be happening at the level of the pharyngoesophageal segment. So there are some strengths and weaknesses or limitations of using fees in this particular patient population. Some of the emerging technologies that I mentioned earlier that may not be as readily available in an everyday clinic are high resolution manometry, which gives us pressures along the entire pharyngoesophageal segment in real time. So this can really give us the numbers-based data that we might need to quantify the force versus resistance factor in the system. And then EndoFLIP, the FLIP stands for Functional Lumen Imaging Probe. And what this technology does is it measures the cross-sectional area and the distensibility of the PE segment simultaneously. So it directly quantifies resistance, which, as we've said, is a critical consideration in this patient population. So it may give us the ability to target treatment decisions and what needs to happen next more specifically. So both of these tools look more at the pressure and flow based concerns that we may have in this patient population. All right, so we're going to just go through a quick case example to look at how we might evaluate and treat in this particular population. So this individual, he's an entirely fictional character here, including the image that I created for him. He is a 62-year-old male, status post-total laryngectomy. He had a primary closure of the pharyngeal defect. He does have a chemoradiation history and is about 18 months post the conclusion of that treatment. He's an electrolarynx user, so he had no tracheoesophageal puncture, no voice prosthesis, and he is consuming a full oral diet. The story behind his chief concern is that it takes him 45 minutes to an hour to eat a meal. He has to use a liquid wash after nearly every bite of food. He avoids bread, meat, and rice. So he's kind of self-restricting certain consistencies and certain foods. He feels food kind of hang up within his throat, and he does avoid restaurants and social meals. So why is this happening? So we're going to just look at a little bit of his swallow study. Okay. So again, we can look at the oral phase. We can see some issues there. Within the pharynx, there's a few notable considerations. We do have a pseudodiverticulum or pouch right here, kind of at the level of C3 to C4. And as we watch the bolus flowing through, we can also see that there are some areas where the lumen is narrowed. So there is resistance to the bolus flow within the mid portion of the neopharynx and then a little bit lower in the area of the pharyngoesophageal segment. Hopefully that turned off. Okay. So now that we see a brief view of the swallow function, um, here's where we can interpret that information. We want to think about that pressure and flow framework to guide our clinical reasoning and how we select our management approach. So is it a pressure problem? Do we think there's inefficient propulsive force? Is there an issue with the tongue-based retraction, pharyngeal contraction, or movement of the bolus through the pharyngoesophageal segment? Is it a resistance problem? Is there a potential issue at the level of the PE segment? Is there fibrosis post chemoradiation? Is there stricture or narrowing? Are there structural deficit or structural differences like a pseudoepiglottis or pseudodiverticulum? Or is there a combination of both? So for him, why does the food get stuck? It's a little bit like a traffic jam, right? So there is some structural bolus trapping, right? The bolus is getting caught in that pseudodiverticulum. It kind of, another term that you'll see sometimes is a pseudovallecula, right? So it looks like a vallecular space, even though it's not. It's a pouch, and we see that the bolus is getting hung up or stuck in that area. Reduced luminal diameter. So there is narrowing within the neopharynx. So we do have some increased outflow resistance. So there's resistance to the bolus flowing through the new pharynx, and the result is residue. When there is accumulation of residue, the patient is depending on that liquid wash to help it clear through that space. And the impaired swallowing efficiency is resulting in prolonged meal times. And together, all of these issues are resulting in social avoidance, where the individual doesn't feel comfortable eating out in a public domain. So how do we select treatment approaches for each of these issues? So when it comes to structural narrowing, when we see a stricture or an area of narrowing within the hypopharynx, obviously that's not something that as an SLP we can change through any type of behavioral intervention. So this would be something that would require surgical consultation for example, for a dilation. And there's different techniques for dilation, like using a balloon for dilation or bougies. So there's different techniques, surgical techniques for dilation. For something like a pseudodiverticulum, like that pouch, that may require structural revision, especially if it's really creating an issue in terms of bolus flow or trapping that bolus. The procedure that is done to address these issues is known as a pseudodiverticulectomy, where they surgically kind of manage that redundant tissue so that it is no longer blocking the flow of the bolus. For residue, we may consider behavioral compensation. So again, these are things like double swallow or multiple swallows per bolus, use of a liquid wash, a head turn or tilt, a chin down posture. And then for the efficiency, we may consider swallowing rehabilitation approaches. So use of an effortful swallow, lingual resistance training to try to build up the ability of the tongue to create that driving force. We may use the Misako maneuver. We may include manual therapies to address the issue related to efficiency. So for this particular individual, after including those approaches, both surgically based interventions and behavioral and rehabilitative approaches, before it required a liquid wash for every bite, after rarely needed the liquid wash in order to clear. Meals, again, took 45 to 60 minutes, but after intervention, meal durations normalized, food sticking resolved, and social avoidance returned to eating in public. So I am based in the Philadelphia area. So again, I made my character, Mr. J. His return to social eating has been going back to the ballpark and having a beer and a hot dog as a result. All right, so when we talk about our treatment framework, again, we match the treatment to the underlying mechanism. So is it a pressure deficit? Is it a resistance problem? Is it a combined pressure and resistance problem? And we use our diagnostic tools to help us decide upon the best approach for treatment. So there, again, there are behavioral management approaches. This is where we may use compensatory strategies, maneuvers in order to help facilitate that bolus flow. So again, this could be liquid washes, multiple swallows, diet modifications, postural modifications, head turns, head tilt, chin down, head extension, anything that might help with bolus flow. Rehabilitative management, again, this would be exercise-based interventions to target underlying areas of weakness or impairment that would impact the generation of pressures to drive the bolus. So we may work on effortful swallows, lingual resistance training, again, to try to improve the pressure generating capabilities of the tongue to create that driving force to propel the bolus through the neopharynx. And then again, we may consider certain modalities. There is some evidence for chin tuck against resistance and jaw opening against resistance, as well as the effortful swallow. Intuitively, the CTAR and the jaw opening, in an intact individual is supposed to help strengthen those laryngeal extrinsic muscles for high laryngeal excursion. But there is some evidence in the literature showing that participating in these exercise tasks has been helpful in this population in laryngectomy. We might consider a modality like neuromuscular electrical stimulation, not on the anterior neck, because all of those muscles that we would typically target are no longer there, or they don't have their attachment point anymore. But if somebody had an issue with developing intraoral pressure or achieving an anterior labial seal, we may potentially consider using that modality to help with the orofacial component or orofacial strengthening. We may use surface electromyographic biofeedback as well in this population. And medical and surgical management, dilation or stretching, Botox injections to address increased tone, myotomy or surgical resection of the cricopharyngeus muscle, or structural revisions, again, to address things like pseudoepiglottis or pseudodiverticula. And then I mentioned internal lymphedema earlier, and that requires its own set of interventions to optimize the tissue to reduce resistance. Again, this could be a whole lecture on its own in terms of managing lymphedema, but internal lymphedema management, it's an integral component to managing dysphagia in not only total laryngectomy when it's present, but also in other types of head and neck cancer. So typically this does require a manual component, manual lymphatic drainage, compression, exercise, skin care, and training the patient in self-management. So to conclude, three clinical takeaways. There are key principles for rethinking dysphagia management after total laryngectomy. Again, shifting from that traditional airway-focused model to a bolus flow and efficiency framework. So again, having no aspiration does not mean that swallowing is normal. And I think this is probably one of the biggest misconceptions on the part of patients. You may see them for preoperative counseling and explain that there can be challenges with swallowing. The surgeon may mention it, but patients often are not expecting it post-operatively. In their mind, this is going to eliminate any swallowing issues that they might have. But unfortunately, there are still challenges to swallowing, as we've discussed this evening. Again, think about bolus flow, think about the resistance and the pressures as opposed to airway protection concerns. And just like treating in an intact system, match treatment to the mechanism. So we still have to determine what the dysfunctional components of swallowing are, and then why that's happening so that we can match the most appropriate interventions to address those issues. All right, so I know it's a lot of information in a short period of time, but I want to say thank you to everyone for being here this evening. Thank you to Brooke and to Tim's University for offering these educational opportunities to everyone. And if we don't have opportunities to answer your questions this evening, I'm always happy to answer those questions at any point. I'm sharing here my Instagram handle if you want to connect that way, and my email so that you can reach out. Always happy to help troubleshoot, problem solve, provide resources. If I can do that, please feel free to reach out.
Awesome. A couple of housekeeping items, and then Kelly, I think there were some questions, so I don't know if you want to
Okay,
answer maybe the two in the Q&A, but I know there were
okay,
some questions about ASHA CU stuff, so I'll wrap that up and then let you do the questions.
sure.
So as I mentioned at the beginning, this course is eligible for 0.1 ASHA CUs, and I put the survey in the chat. It'll also be sent out to you via email from Zoom within 48 hours. The replay and Kelly's slides will also be up on the Tim's website via the link that I put in the chat, which will also be sent out via email from Zoom. And then if you want a certificate, just send us an email at tims-tims.com. Typically, we get back to those within 24 to 48 hours, but sometimes it does take 7 days because we also practice clinically. So with that being said, I'll hand it back over to Kelly so she can answer those couple of questions.
Right. Yeah. So in the chat first, there was a question about whether or not I think patients are aware of the potential for dysphagia depending on the type of reconstruction. And I think it really does depend. I know the protocol at my institution was that everybody would see speech pathology before their total laryngectomy procedure. And as part of our session, we did talk about, the likelihood of the different issues that could come up postoperatively, including challenges with swallowing. And we would go over the timeline of, you're not going to be allowed to eat anything by mouth for, probably 10 days to a couple weeks after the surgery to let everything heal. And then we have to take a look at how things are moving. So there is that discussion. But I think that when problems do arise, patients are often surprised, right? Because most of their impression is that, most of the time they're coming into the total laryngectomy surgery with some degree of dysphagia at baseline because of their laryngeal cancer. So they're coming in with some degree of dysphagia, and they're in their mind, they're going to go through this big procedure and it's going to at least, I'm going to lose my voice. And yes, there's options to communicate alaryngally, and we talk about that, but they're thinking at least the swallowing won't be a problem. I don't have to worry about aspiration, or, I don't have to worry about pneumonias and those types of things anymore. But I do think in general, there's just so much that gets presented to the patients. It's very overwhelming. And even if they do hear it, they may not fully grasp that concept until they're actually in that situation where they're experiencing difficulty. So I guess the answer is yes. I think it's something that is often mentioned, but A, you don't know if it's actually going to end up being a problem for them, and B, they may not really be hearing that up front. So it can be a challenge to balance the counseling and balance, what the expectations may or may not be. And then for in the Q&A for brand new post-op laryngectomies, if leak study is passed, do you feel best practice is for SLP to conduct a clinical bedside swallow? On that same note, do you feel that MBS is indicated? So I think a lot of this may depend on the workflow and the pathways that are established in your institution. Where I was typically if they passed the leak test, which we weren't always involved in that, because they're just looking for any potential leaks in radiology and not necessarily doing a physiologic study. If they passed that, there was then kind of that protocol where they began with liquids and then slowly advanced to more challenging textures. So I would say in our workflow, we didn't perform, an MBS or fees at baseline. We kind of started them through that protocol of starting to eat and drink. And if there became any concerns or, it was problematic, that's where we would then complete the modified barium swallow to identify what was happening. But we didn't necessarily include it as a baseline. And that's not to say you couldn't, if that was part of the pathway to clear someone to eat and drink and do a baseline modified. That would certainly give you plenty of information to make recommendations in terms of advancing or whether any strategies might be necessary. So I would say it could go either way depending on the institution and their preferences and kind of how you can, if you have the resources to implement that type of pathway. And then do you feel that patients with total laryngectomy are more or less aware of the residue from a sensory perspective? Yeah, so I think that's a great question and interesting one. I feel like, from a purely anatomic perspective, when you're thinking about reconstructions and, use of tissue that's harvested from elsewhere in the body, it's also insensate. It's not going to have the ability to transmit sensory information like, temperature, pressure, where the bolus is located, proprioceptive based information, because it's tissue that came from the thigh or from the arm or from the chest or back. And it doesn't have connections back to the brain to send those types of signals. So in theory, you would think they would have no sense of there being residue, but I feel like subjectively, based on clinical experience, my patients seem to be very in tune with residue and that sensation of food getting stuck. And so my thought is that most of that sensory feedback is probably coming at the level of the pharyngoesophageal segment or upper esophagus. So it's almost like the referred sensation that people get when they have esophageal dysmotility or esophageal strictures, where, even though it's in the esophagus, they're saying they feel it, in the throat or they feel it in the pharynx. So that would be my best guess as to why they do seem to have some sense of, there being residue present. Right?
Well, I know we didn't get to all of the questions, and there were quite a few pretty in-depth questions in the chat. So
Okay.
please, reach out to Kelly. She's got her email on the
Yeah,
screen here
please.
and Instagram. So
Mhm.
we just again want to thank you all for being with us this evening, and thank you, Kelly, for providing your expertise. There were a ton of messages thanking you for your presentation tonight and saying how
Oh,
great it was.
great. Awesome.
Um,
Yeah. And I'm serious. Email me if you have a question that we didn't get to answer. I am more than happy to answer it. And the handouts will be available, and there'll also be a document that has some of the references and sources that I cited so that you can go seek those out if they're helpful to you.
Awesome. Well, thanks, Kelly, and thanks everyone for being with us this evening.
Oh,
And we hope to see you at our next sessions coming up in July. Bye, everybody.
thanks, everyone. Have a great night.